Good morning and welcome to a special segment of the Republican Hour with Charlie Copeland. It's good to see you this morning, and I hope you get a chance to get out and enjoy the day later on. We have a special segment this morning. I have a special guest, Dr. C.L. Gray, who's here to talk about healthcare in the United States. Obviously, the healthcare debate's been going on for a number of years now, and we're not really here to talk about the Supreme Court decision because, frankly, as somebody that believes in the rule of law, when the Supreme Court says this is how it works, then this is how it works. And Congress has the ability to tax anybody for any purpose at any time. And the Supreme Court said that the health care bill was a tax, and so there it is. It's a tax. But the question isn't so much whether this bill was or wasn't, how it was developed, or anything. What is the right healthcare system? The World Health Organization, which is an entity in the UN, ranks the United States as the #1 healthcare system in the world in terms of responsiveness. And frankly, when it comes to healthcare, I want responsiveness. And so how do we maintain that, but maybe make it more affordable or access to more people? What's the right way? And Dr. C.L. Gray, who's here with me this morning, is an expert in this field, has spoken across the country in it, and I feel very fortunate to have him here this morning to talk about it.
It's great to be here. Thanks for having me.
Gray. Absolutely. So, obviously, healthcare and where we go with healthcare in the United States has been a big issue over the last few years and will continue to be such. Talk to me a little bit about why a government-run system is not a good foundation to start a healthcare system.
Well, Americans, as you know, are among the most compassionate people in the world. And of course, every American wants our fellow Americans to have access to health care. And that's true left, right, and center. So that piece isn't really political. Where it starts getting to be more difficult then is how do you achieve that goal? And there's a phrase I have, and I'll tell you a story in just a bit, but government compassion sounds so noble, but in the end, whoever pays has the power to choose.
Sure.
So as we shift money to Washington to provide for health care for everyone, we shift power to Washington. And as power moves to Washington, we the people, patients and physicians, lose the ability to control our own healthcare decision making. And that's especially true when it comes to the increasing national debt, because at some point the government runs out of money to provide these services. Back when we started debating healthcare reform, the total national debt was at about $10.6, $10.5 trillion. Now it's at about $15.8 trillion. So just in the last 3.5 years, our national debt has increased by over $5 trillion.
And to put that into some perspective, because million, billion, trillion, they all rhyme, and it's kind of hard to get your arms around them when I'm used to numbers like I buy a dozen eggs.
Yeah.
I don't even know what a trillion eggs looks like, but the entire U.S. economy, so everything, 50 states, millions of jobs, the entire U.S. economy is about $14 trillion. So our debt now is larger than our entire economy generates in a year.
Yeah, so if we took every dollar generated in the U.S. for an entire year, which means no one, businesses included, would have an income, we wouldn't even pay off our debt.
Right, so I just try to give it some
Absolutely.
perspective.
Another perspective that the audience may appreciate is interest on that debt. Right now we're at historic lows in terms of interest rates, and if we go back to a norm of 5 or 6%, interest on that debt will be more than we pay for the entire Medicare program and more than we pay for the entire Medicaid program.
So right now with Medicare and Medicaid, so the government-run healthcare systems today, and many of the viewers are going to be on either one of those two systems. The money that's being spent on those programs today, if interest rates go back to 5%, which is where they've been most of the time
That's a historic
for
norm.
200 years, the interest payments that the government will owe on the debt that we have will be more than those two systems that, again, many people who are watching. So what you're sort of saying is where are you going to come up with the money to make those interest payments
Yeah.
if we don't take it from other services like healthcare?
And then the question comes, what happens when the government starts to run out of money? And maybe if I can take a moment just to tell you a story. There's
Sure.
a lady out in Oregon, Barbara Wagner. She is 64 and she had recurrent lung cancer. And she went to see her oncologist and he recommended treatment with Tarceva. So she went to get her chemotherapy, but she found out she couldn't. Reason why was she didn't have insurance. Well, like a lot of states have to struggle with this question of the rising number of uninsured. The way Oregon dealt with it was to develop the Oregon Health Plan. So Barbara fell into this government-run system very much like the Patient Protection and Affordable Care Act, which is now the law of the land at the national level in terms of our healthcare system. But the Oregon Health Plan was running short on money. So they had to start to decide who gets what. So when Barbara went to get her chemotherapy, she couldn't. Instead, she got a letter from the state of Oregon saying, we won't pay for your chemotherapy. Instead, we'll either pay for hospice or for physician-assisted suicide. The problem is Tarceva, the chemotherapy, is about $4,000 a month. Physician-assisted suicide held a one-time cost of $100.
Right.
So essentially, for Oregon and for Barbara Wagner, it boiled down to accounting. She had become a negative economic unit.
So instead of the healthcare system in Oregon working to find a way to help her live, they basically gave her an option on how to die.
That's absolutely it.
And
They had run out of money. They couldn't afford to deliver the care that she needed. And the problem is that we have to struggle with as a nation is we have this rising cost of health care. It's devastating American business. It's driving us into debt at the state level and at the national level. So you are essentially left with two choices. You either start to limit care for those on a government system, or you find another way to make it more efficient.
right.
And those are the choices.
So we either limit care or make it more efficient. And I have to say, I'm not familiar with too many government programs that are very efficient.
Sadly so.
Efficiency is not.
No, that's not the strong suit.
There's some good things that with making sure that people play by the rules, but efficiency isn't one of them. So, and the story you tell of this woman in Oregon who basically was told, no, we don't have money in our budget to help you live, so we're going to tell you how you can die. And those stories are all too frequent coming out of England, which has had a universal healthcare system for a long, long time. And my understanding is that Dr. Ezekiel Emanuel, who was the brother of the former chief of staff, who's now the mayor of Chicago. He's a quote unquote medical ethicist who was very, very much involved in this. And I read a number of years ago a paper that he wrote 5-6 years before that, so in the early 2000s or so, that I found frankly horrifying in its descriptive of, well, there are people that are just not value adding in life anymore, and so we should get rid of them.
Yeah. And maybe I'll step back a ways, in some ways a long ways, back to ancient Greece, okay, 2,500 years ago. And I really got into this back in the mid-1990s when I read a book by Peter Singer, struggling with the issue of healthcare. And to hop to Peter Singer briefly, he wanted to change the definition of human life so that humans were, quote, fully human when they were born. They wouldn't be considered fully human until they were 28 days old. Again, this is after.
So you had to be 4 weeks old before you were
actually
actually
had to be 4
a human.
weeks, yep, actually 5. If you survived your 4th week,
Right.
you got human when you get your 5th week. But his argument was if you were born with a disability, that we should think of reinstituting infanticide to kill the kids with disabilities. So we could take that money that we'd saved by not treating kids with disabilities and treat kids that are much more gifted. So I was wondering how on
In his
earth...
definition of gifted.
Yeah, or producing for society.
Yeah.
Because that's really the hinge this all turns on, is what we're seeing now is a fundamental change of the patient-physician relationship. And there's really only 2 roles for the physician in the last 2,500 years. Well, either follow Plato, and in his Republic he talks about the physician looking for those that are contributing to society and treating them. Those that are a burden on society, young kids with disabilities,
The old
folks
and
over
infirm.
65, they're either killed or let die. Because his definition of good was to move society forward. And if you're a burden on society, you're expendable.
Right.
The counter to that was Hippocrates, was actually a contemporary of Plato's. Plato was born about 429 BC. Hippocrates is born about 460. But Hippocrates started with a model where the physician was devoted to the individual patient.
Mm-hmm. So it was a doctor-patient relationship,
Absolutely.
not a doctor-society relationship.
Yep.
It was a one-to-one, not a
Yep.
one-to-many or what have you.
Yep, where the physician is looking out for that individual patient instead of the greater good of society.
Mm-hmm.
And I won't cover it here, but trace that thought through the next 2,500 years, and I do that in the book, The Battle for America's Soul. And you can see this needle of the sort of medical ethical compass swinging
Right.
back and forth between Plato and Hippocrates
Mm-hmm.
as time goes on. That's really what underlies this healthcare debate.
Right.
Is what is the role of the physician in society? Is the role of the physician, by extension, what does it mean to be a patient?
Right.
Is the role of the physician to look out for the general welfare of society, including its economic good? So folks like Barbara Wagner that are very expensive to care for,
Right.
they're sort of set aside.
Right.
Or kids that are born with disabilities,
Because they're no longer
they're set aside.
valuable.
They're no longer positive economic units. They're negative economic units. So we can either follow a government-run system. The only way you can control cost in a government-run system is to limit care.
Mm-hmm.
And that's just the model they have. There's an old phrase, if the only tool you have is a hammer, every problem looks like a nail.
Right.
So if the only tool they have is to regulate and legislate, we're never going to fix the problem.
Right.
So you have to limit care. And it's interesting, we mentioned Ezekiel Emanuel earlier, but in January of 2009, he published a paper in The Lancet, a very respected medical journal. And he introduces something called a complete lives system. If you look at the left of that curve, that's birth, age 0. That age at the bottom of that curve spans from about 0 to 70. And on the left-hand axis, there's the probability of receiving an intervention. So his argument in the complete lives system is when you're young.
Now this chart came from his
Paper. The graph that your audience is looking at came directly from Ezekiel Emanuel's
from one of the
paper.
guys who was the architect of the Affordable Health Care
He
Act.
helped put this all together. Yes,
Yeah.
he was working in the White House when this whole legislation was assembled. So on the left-hand end of that curve, you see those that are very young have a very low probability of receiving a medical intervention. By the time you reach about age 15 to about age 45 on that graph, your odds of receiving a medical intervention are much, much higher, because those are the people producing.
They're productive for society.
Yes. And if you look on that curve, if you're over the age 50, 55, the probability of receiving an intervention again drops off. Now I ask you, looking at that curve, how do you cut $575 billion from Medicare? Which is what this bill does. It's right there on that curve. You just limit access, like
Right.
the story of Barbara Wagner.
And so you take that percentage of probability of health care intervention and you just drive it down to 5%, 4%, 3%, whatever it is, because those are non-productive people, and therefore we've got to save $500 billion. And the easiest way to do it is just to say, well,
Just
we've
to
rationed care.
limit access to
and
care.
And so you can't, I'm sorry, you don't qualify because you're no longer productive.
Yep. And that's the philosophy. And if we had an hour to go through this, I could walk you through each of the thinkers that moved the ball this direction. But I'm sure this is right because I predicted this back in my first lecture in 1999. So it was 13 years ago. I was concerned this is what was going to happen. Now here we are,
Right.
13 years later.
Now, you as a doctor, and you're an internist, so I mean, this has been your profession for years and years, and I believe you're in North Carolina. Is that?
Yeah, I practice down in North Carolina. I'm a hospitalist, do hospital-based medicine, critical care.
Yeah, and so I mean, you see this firsthand as a physician, the decreasing ability for you to work one-on-one with your patients.
Yeah, and the increasing inefficiency of the system, where now medicine is getting to be much more about is the chart and paperwork filled out correctly,
Right.
not what actually happens to the
I
patient.
mean, one of the things that I heard all along the way was these insurance companies are making all this money, and they're wasting all this money on marketing and paperwork and so on and so forth. And so we've got to get rid of those insurance companies because, first of all, they shouldn't be making any money on this, and second of all, they're wasting money on marketing and what have you. And therefore, we need to have government do it because that way it's one single payer and all that inefficiency goes away. But there is another option, and that other option is the patient-doctor relationship, so that I'm not replacing an insurance company bureaucrat with a government bureaucrat, but I'm replacing all bureaucrats with a doctor-patient relationship.
Yeah, and it's interesting if you compare the previous U.S. system to Europe, because a lot of times we're told how wonderful things are in the European healthcare system. In my book, I actually lay out 5-year cancer survival rates. And I'll just read a couple of them to you. For breast cancer, these are the percentage of people alive at 5 years after diagnosis with a cancer.
So a higher number is better.
Higher number is better. Europe, breast cancer, 79% are alive. America, 90%. Prostate cancer, Europe, 77%. America, 99%.
99.
And if you go cancer after cancer, the survival rates are 10, 15, 20% better under the American system than the European system. So if we're moving to a European-style system, we should be expecting European-style outcomes.
So instead of 90+%, we're looking at 75 to 80%, which means that 10% of the population will be in those populations that
if
get
they
that
have
cancer, can expect to die.
Yeah, that wouldn't
Under
have the previous
and
system.
again, that comes down to back to the UN when they globally looked at healthcare systems, and they said the United States has the most responsive system in the world. We were number one, but what they didn't like was how we paid for it. And they said, we want you to pay for it like somebody else does, like the Europeans or somebody else. But they didn't connect the dots that maybe ours is more responsive because we still have some of that doctor-patient relationship, despite the inefficiencies of the insurance companies and things like that.
It's also interesting if you look at some of that other data. A lot of times people quote data saying Canada has a longer length of life, longer longevity, and than America, and therefore the Canadian-style system must be better.
Right.
Turns out when you account for homicide and motor vehicle accidents, Americans live longer than Canadians. It's just we have such a high
homicide rate and a lot of bad drivers.
Yeah. So and then of course brings the average down.
Right.
Same thing happens when you look at the infant mortality. Say, boy, the U.S. has much worse infant mortality rates than other countries. Well, it turns out that comes because how they count a live infant. In America, if the infant is born breathing with a pulse, it's considered a live birth. In countries overseas, sometimes they have to meet age requirements, weight requirements.
So there's a different definition of what is alive.
Yeah. So if they're premature, they're not considered a live birth. Where here, we would actually try and save that infant, even if they're born premature.
Sure.
Another country, they wouldn't even attempt to save that life.
Right.
But they don't count it as live birth. So their rates look better. So there's so much of what's been sold to the American people that's just manipulation
It's a
of the
little
data.
bit like the unemployment rate. I mean, they've changed the definition of the unemployment rate in the early 90s. And so now people who are no longer looking for work but are not employed, they don't no longer count it. And so we say, oh, the unemployment rate's 8%, when the unemployment rate is really more like 17, 18%. But nobody wants to say that this is depression era numbers because then nobody gets reelected. So we'll change the definition. And it sounds like other countries have changed their definition or just have a different one because they've got a different philosophy about human life.
Yeah, and that can be it. Because we've very much respected human life here in our healthcare system.
Still.
And we still do. To a degree, it's just the question of which direction this needle is going to swing.
Right.
Or is it going to take us back to Plato, or are we going to continue to follow Hippocrates? But then the question comes, we can't just bomb throw. I mean, there's a ton of things wrong. The things that concern me about this legislation the most is the $575 billion cut to Medicare. On top of that, there's another $300 billion cut to physician reimbursement for Medicare. So there's almost $1 trillion actually
that's been pulled out of the
been
system.
pulled out of the system. And they had to do that so that Washington could come to the American people and say, we're going to, quote, reduce the deficit.
Right.
And we all remember that. The deficit was supposed to have been reduced by $143 billion.
Right.
Well, as it turns out, they said the healthcare legislation then would cost $789 billion. But that didn't account for most of the spending.
Right.
And that got recently revised upwards to $1.76 trillion.
And that's by the Congressional Budget Office.
By the Congressional Budget
which is
Office.
A nonpartisan.
And that still doesn't include all the costs. Once you include all the costs, the number comes in about $2.3 trillion. So
which again, in
it's about
scope,
triple,
yeah.
Which is just going to expand the debt,
so
putting more pressure
what
on the
do you
system.
do?
Well, I've written a policy paper. It's called Cutting the Gordian Knot, a patient-centered, fiscally responsible plan for healthcare reform. So what I do to begin with, what was never discussed with the American people, just lay out some guiding principles. How do you engage a complex system? So I lay out 5 rather simple ideas. You craft a series of reforms, each reform addressing one clearly identified problem in the current system. Find one problem, generate one answer. Find a second problem, solve it. Pass each reform separately. So there's no pork, no payoffs. Write each bill using an understandable format, keep it to a reasonable length. Keep each bill clean, letting it pass or fail on its own merits.
Right.
And then let the American public actually see each section for 7 days prior to voting.
Right.
So it's basically saying, going to the American people saying, here's the problem, here's the solution, one thing at a time.
I mean, one of the things in the debate, they said there are, I don't know, 35 million Americans who don't have health insurance. And then when you start to dig into that number, about half of those were young people who were choosing not to have health insurance. And there could be a solution to that. Okay, if we got 15 million Americans who are young and healthy and choose not to have health insurance, there's probably a way to address that as a standalone problem.
Yeah.
And so that took that number down, and I forget, there were a couple other little things, but it ultimately came down to about 10 to 12 million Americans who
really
needed health
really
insurance,
help.
who did not have it.
Yeah.
And again, I mean, 10 to 12 million Americans in a country of 320 million people is, what, 1%, 2%, something like that? And that's a problem that's solvable without spending $3 trillion.
You don't have to change the system for everybody, especially pulling almost $1 trillion out of Medicare.
Right.
This is going to devastate the Medicare population. And I imagine many of your viewers now are having trouble finding a physician.
That will
if
take
they're over.
Medicare or Medicaid.
Medicaid is even worse.
And Medicaid in the state of Delaware is the largest single budget item, and in a couple of years it will, in total, be more spending than we spend on education. And it'll start to take money out of everything else.
It's consuming the budget. In the back of my paper, I actually run through state data, looking at exactly
And back in
that.
2007, when I was still in the legislature, I actually issued a policy paper that talked about that growth trend and gave some ideas of what we could have done back in 2007 to have helped add some flexibility to the system, put some managed care around some of the chronic conditions, and of course nothing was done, and we're now 5 years later, and the problem is even much larger today.
Yeah, I think we're almost out of time, but I'll just give, there's 17 ideas laid out here, but I'll just take the first one just so your audience knows there are alternative solutions. First one solves both the Medicare and the Medicaid problem. There's January of 2013, a 30% cut coming to physician reimbursement for Medicare patients, for seniors. So seniors, if that goes through, won't be able to find a physician.
Right.
We have to generate about $300 billion to fill that hole. You can do that by restructuring Medicaid using a Medicaid block grant. If we block grant Medicaid, we can re-inject efficiency into the system. A lot of what's driving cost of Medicaid up for states is the crazy strings that come from Washington.
Right.
What you do is block grant that money, and I go through that in detail in my paper. If you block grant the money, it gives states both the incentive and the ability to run lean, efficient Medicaid systems. Right now, actually, if you look at patient outcomes, you have a better patient outcome on average with no insurance than you do if you have Medicaid, which is really sad. Why we're spending $400 billion a year to have worse patient outcomes. That has to be addressed.
Right. Well, Dr. C.L. Gray.
Well, thank you so much for having me.
Very, very great pleasure for me. And,
Time went fast.
I guess it does. And I guess to summarize, there are lots of different options that we could follow for healthcare, and from my perspective, I don't want an insurance industry bureaucrat deciding my healthcare. I don't want a government bureaucrat deciding my healthcare. I want my doctor and I
That's
to
the way it
decide
should be.
my healthcare. And there are ways to do that are affordable. There are ways to do that are sustainable. And this debate hasn't been about that. This debate has been about who controls those dollars and who gets. And when the Supreme Court announcement happened a little bit ago, the next day, hospital stocks, publicly traded hospital corporations, their stocks went way up because hospitals get a lot out of this. And that's a problem because we're picking winners and losers. So, C.L. Gray, Dr. Gray, I appreciate it.
Well, thank you for your time.
And we'll see you at another segment of the Republican Hour. This is Charlie Copeland. Thanks for watching.